All right, guys, this is differential diagnosis of the hip, compressive neuropathy disorders. Let's get into it. We're going to start looking at two main ones that are actually hip generated. A lot of the things we think about for neurological symptoms of the leg start in the lumbar spine and travel downward. So the knee and the foot and ankle, they also have some compressive neuropathy areas. The hip, not so much. There's a couple of big ones here. Those are going to be Piriformis syndrome and Meralgia, paresthetica. And so we'll try to get through those and see if we can kind of distinguish or delineate between other things, from a differential standpoint. How do you pinpoint these two? So again, let's review some anatomy. And so here we have some of the similar pictures we've gone over in other lectures, but I want you now to draw your attention to the neuroanatomy here, the peripheral nerves exiting the lumbar spine. You can see just how complex and how many different cords and trunks and things there are that branch out and innervate the musculature of the hip. And if we keep going here, you can see on the very right side of the page some of the nerves in the popliteal fossa, which is an area where we don't do things like particularly like dry needling and things in this area because it's kind of a soft spot, if you will, that has neurovasculature there. And then here you can kind of see running deep in the leg here, there's a sciatic nerve that's cut here. It travels all the way down the leg, the posterior leg, and then branches off into the calf there. So I want to draw attention to this area where the piriformis is and where the sciatic nerve is, because we're going to be talking about that next. You also have in the front of the hip, if we remove the musculature and just look at the neuroanatomy, you have your lumbar plexus that branches off, turns into your femoral nerve. This is why we think that L2, L3 nerve root compression might give you more anterior thigh pain. This branch off here is going to be, one of the things we think about for like, femoral nerve injury branches, if you will. There's another nerve that pops out here, so I was thinking this was it, but then I was looking at this, it's a little higher up. It can give you Meralgia paresthetica, so we'll look at that as well. So here's some of the nerves of the glutes, and then again, here's your biggest nerve, peripheral nerve in your body, or sciatic nerve. So you can see how large that is. Again, just some more pictures here. Here's the inguinal ligament I want to draw your attention to, and at this area, the nerve that innervates the skin of the anterolateral thigh can get impinged, and that's what Meralgia paresthetica is. And so we'll go over that as well. Here's some other branches of the nerve. Lateral cutaneous nerve of the thigh is what we're talking about here with lateral femoral cutaneous nerve is what it's called. That gives you Meralgia paresthetica in this area. But I want you to draw attention again to the nerves of the leg that travel all the way down to the foot and ankle, okay? And then again, this is a picture of the posterior thigh with muscles resected or retracted, and you can see how big the sciatic nerve is on all the branches that come off of that. And so just think back to the hamstring lectures. We have to distinguish if someone has a hamstring strain or they're having some adverse neural tension through the sciatic nerve secondary to a mild hamstring strain. If they're not making progress, are they having more adverse neural tension from like a protective response at that point, or is it truly just the muscle tissue or the tendon tissue that's irritated? So a little nuance there. Don't forget your dermatomes. Simple statement there. You have to keep practicing these and understand where they show up. And someone comes in with L5, numbness or whatever in their shin, are you going to assume that that's from the knee? Well, maybe not, right? You probably need to look up the chain and assess their lumbar spine and maybe their hip as well. So piriformis syndrome is a condition that occurs when the piriformis muscle located in the buttock region becomes inflamed or irritated and compresses the sciatic nerve. Piriformis muscle becomes tighter and inflamed. It can put pressure on the sciatic nerve, which runs through or under the muscle in some people. It can cause pain, numbness, tingling in the buttock and down the back of the leg. It kind of really mimics sciatica. Relatively uncommon condition, but its exact prevalence is not really that well known. It's estimated to account for only a small percentage of cases of low back and leg pain. More commonly seen in women than men, is most commonly diagnosed in middle-aged individuals. It's more commonly seen in individuals with anatomic variations. And so if we look at this study here on the right, anatomic landmarks for a safe arthroscopic approach to the deep gluteal space, what we can see is they've really tried to branch out, no pun intended, and see the different anatomical variations of the piriformis and the sciatic nerve. And you can see there are several different ones. There's ones that pierce through the sciatic nerve in different ways. There's ones that are entirely encapsulated by the piriformis. There's some that are at the inferior angle, all these different variations of how the sciatic nerve branched through or around the piriformis. And so we have to take that into account. There may be anatomical variations here at play with people who truly have this. Most people are going to fall into this A bucket, and then of course these are just variations of normal. So, oh, by the way, if you have an anatomic variation, it doesn't mean you're doomed to get this either, right? There has to be certain, it's multifactorial. Symptoms of piriformis, again, can vary, but might be pain in the back or buttock region, pain and numbness in the back of the leg, tingling, pins and needles in the affected area. And that doesn't mean the butt, but that means basically down into the leg, into the foot, and difficulty walking or running, maybe due to pain or discomfort or numbness or tingling. Differential diagnosis includes sciatica, lumbar disc herniation, sacroiliac joint dysfunction. You also want to think about hip joint pathology, myofascial pain syndrome, spinal stenosis, tumors, masses, anything that might impede or compress that space. So the test that we do for this in the clinic, one is called the piriformis muscle stretch test. I'll have you look that up, and these other ones as well. The Freiberg test, the pace sign, the Beatty test. All of these are trying to contract essentially or stretch the piriformis in an isolated fashion to see if it puts extra stress on the sciatic nerve. Palpation deep into the buttock region can also be used to identify this. If you push into someone's piriformis and their leg starts going numb, that may be a sign that they have true piriformis syndrome. If that they're having sciatica type symptoms down their leg and you push in the piriformis and it's just tender in that area, you probably don't have true piriformis syndrome. It might just be taut or hypertonic muscle. So what do we do for interventions with this? Well, stretching exercises help to improve flexibility, reduce tension in the piriformis muscle. Strengthening exercises can help to improve muscle imbalances and support the hip and pelvis. Soft tissue mobilization techniques, if they're symptomatic, then you think soft tissue mobilization, modalities, education on posture, body mechanics, stretching, so on and so forth. And next, let's talk about Meralgia paresthetica. So what is this? It's a condition in which the lateral femoral cutaneous nerve, you sometimes will see that written as LFCN, supplies a sensation to the outer thigh. That becomes compressed or pinched, leading to pain, numbness, or tingling in the outer thigh. And this region where it's shaded in on this individual in the bottom left of your screen and the bottom right of your screen, that's the area where someone's going to be complaining of this numbness sensation. Sometimes they'll complain of it feeling like cold water running down their leg, or just a patch, an area of skin that they just cannot feel. Tactile sensation is reduced or eliminated. Here's the branch off of the nerves here. You can see how this one nerve crosses under the inguinal ligament. It can get compressed at this area and then give these sensations down the leg. So what are some general considerations here? Well, tight clothing or belts. So, wearing belts around the waist or hip that can put pressure on the inguinal ligament can compress the nerve. We would think of someone like someone working with tools like this, a construction worker or a carpenter, someone that has to wear heavy belts might happen to. Obesity, so excess weight can put pressure on the inguinal ligament. Pregnancy, the added weight and the added size of the inguinal area can also compress the nerve and lead to symptoms. And then it can result from injury or trauma to the hip or thigh, leading to compression or damage to the nerve. So if you took a direct blow to this area, there's a chance that you could have a femoral nerve, lateral cutaneous femoral nerve injury. Demographics most often occur in 30 to 40-year-old individuals, has a higher predilection in adult males and females, and can technically occur at all ages. But but that's from this study, Meralgia, Paresthetica, review of the literature by Cheatham et al. In the bottom right of the screen. You can reference that article if you'd like. I think I'll probably put that one in your Canvas as well. Signs and symptoms here, numbness, tingling, burning pain in the outer thigh. It's really this patch of skin. So, if someone's complaining of this, it's likely going to be this differential diagnosis, but you're going to have to assess other areas such as the lumbar area, L2, L3. You can see where the nerve roots branch off there. That gives way to this area. So you need to make sure they're not having a lumbar disc herniation, nerve root impingement type of situation there. That will be discussed. We're so close to the end of this term. We're already halfway through. We're going to be looking at lumbar and spine next term, so I'll help you differentiate here. Peripheral neuropathy is always something. Someone with numbness in their legs and their extremities. Peripheral neuropathy always wants to try to see if we can rule that in or out. Hip conditions such as OA, labral tears, or hip impingement. Again, those aren't going to have numbness and tingling, but the location might be similar. Sciatica, spinal stenosis. You guys can see where this is going. Test and measures. There's pretty simple tests you can do in the clinic. Tinel's sign, just like Tinel's with the upper extremity, you're going to tap or press lightly on the area. Sometimes you can even add compression. I just stack two fingers like this, and I just add compression down at areas where I think the nerve is traveling along, and I'll see if I can add extra compression, see if we can elicit symptoms. If the nerve is compressed or irritated, it may cause tingling or like an electric shock type sensation. Stretching the femoral nerve, which is pictured in the top right. So basically take them into something that looks kind of like Ober's test, but instead of dropping the leg, you just keep pushing them into hip extension. Sensory testing, and they can do things like nerve conduction studies or EMG testing to this area. The picture in the bottom right is a nerve conduction velocity test. So basically what they do is they hook up needles down the leg, and then they have this probe that sends a shock through that area, and they're looking to see if there's decreased electrical conduction through the nerve there. And they do that based on the nerves, the norms of the speed of which that nerve should have electrical activity. And if you're below that normative value, because they're looking at the velocity of how fast the nerve conducts, how fast the electrical signal travels down the nerve. And so if you're below that normative value, then they're going to diagnose you with something like this if your symptoms also dictate it. So what are interventions we can do? Well, initial intervention is conservative, may benefit from analgesics, NSAIDs, looser clothing, weight loss, femoral nerve glides, soft tissue work around this area. You want to make sure that your soft tissue work isn't aggravating, because we know compression is one of the causes of this, so we don't want to compress directly on that area, but maybe loosening up or doing tissue work or down regulating tone around this area might help things move better. Hip stretching and strengthening, generally speaking, glute strengthening, doing things that are more posterior chain based than anterior chain based, maybe to relieve some pressure from this area. Surgery for severe prolonged cases, basically they'll go in and they'll decompress the inguinal ligament. You can see I've pictured here the inguinal ligament. You can see some muscles that cross under, like the psoas, and then you have the femoral nerve here. So they'd go in and they just kind of release this, or a cut around, do it like a neurolysis, we would call it, to give this more space to move so that it doesn't give symptoms. So here's kind of a little review of compressive neuropathy, and this table I edited to just show the two that we went over. There are other ones in the hip region, and you can find this study. I'll see again if I can upload this too. This would be a little bit of good to know information rather than need to know. But the piriformis and the lateral femoral cutaneous nerve, the compressive neuropathy conditions, those are the two that I want you to know for your exam and things like that. Those are probably the most common. But this clinical commentary by Martin et al. Goes over other ones as well. So you can look that up.